Yeah, hello everyone. Now I would like to invite Dr. Chandan Vinay, who's an RD dietitian at ESI Hospital, Pinai, Bangalore. And he worked as a dietitian at ESI Medical College and also Model Hospital. And is a qualified registered dietitian with PhD in food science and nutrition and MSc in food science and nutrition. And has a lot of achievements and awards, and with the 10 years of experience in exposure to spectrum of nutrition care. And he also presented the best research paper LSME International Conference 2020 and best poster presentation award Indo-Swedish Conference, and second place in oral paper presentation held by Association of Microbiologists of India, and secured first place in IDA President Award, and secured Dr. Padma K. Mapati Gold Medal in 2008. And research side, he has presented in many national and international conferences, and also a few publications where he did a pilot study, Asian phytomedico and clinical research in in vitro starch and protein digestibility of this specific nutrition examination. So we would like to invite you, sir, and please continue the session.
Thank you. The topic for today's talk is dietary approach in COPD, and I'll be covering these subtopics mainly related to the disease in brief, and then into the diet or the nutrition component with the malnutrition and its side effects, and ADIME or the nutrition care process, and the specific MNT and illness that is beneficial in COPD. So, as the disease definition is, it is an obstructive pulmonary disease that is chronic in nature. This is the simple definition. But otherwise, looking at the standard definition given by GOLD, which is a global initiative for chronic obstructive lung disease, it is a preventable and treatable disease which is characterized by persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities. And the major causes here will be chronic exposure to noxious particles or gases. So we have both the important components of the respiratory system involved, or let's say affected in this disease. And the two major phenotypes of COPD are chronic bronchitis and emphysema. So chronic bronchitis is related to the changes in the airway passages, whereas emphysema is directly related to the narrow passages and the alveoli, the exact gas exchange occurs. So inflammation is a chronic feature, mucus hypersecretion, narrowing, and infiltration by aminocytes, which is seen in bronchitis, whereas in emphysema, the elastic structure failure, or let's say failure or loss of recoil is the most important cause there. So as you can see in the image, so the destruction of alveolar walls can lead to trapping of air, or in simple terms, there will be difficulty to expel, or let's say put out the carbon dioxide that is generated. So why is it important? Why is COPD so important? Because it is currently, as per the Global Burden of Disease Report 2009 study, it is the third leading cause of death in the world, responsible for 3.23 million deaths in the year 2009. And currently, more than 480 million people in the world are known to be diagnosed and living with COPD. The major concern is its effect on the quality of life or how people live with the disease. So it is the 7th leading cause of years of life lost as well. Is it the same in India, or let's see? So in India, it's much worse. So in our country, it is the 2nd leading cause of death, again, as per the same report in 2019, and around 37.8 million people in India are known to be living with COPD. It is reported to be about 3 to 8% in men and 3 to 5% in women. And it is responsible for 9% of the total deaths. So the various causes, we know the famous ones, the outdoor air pollution, because even that is a problem which is still persisting in our country. Smoking habits, cigarette and weed, pollutants, exposure, indoor air pollution, even that is important. Smoking or particulate matter, smoking is in the secondhand smoke. The biomass smoke, which is due to burning of the fossil fuels, and various other factors. The symptoms include dyspnea, which is a major and observable, or let's say a symptom of high magnitude that has a lot of impact on the nutrition status as well. Persistent cough, excessive sputum production, wheezing, And the diagnosis chiefly is done through spirometry, and based on the severity, other tests are done. And there usually in hospitals we see COPD patients getting admitted, or let's say as an IP patient when they have an acute exacerbation where there will be a worsening or flare up of the symptoms that is seen. Otherwise, usually they come for a follow-up, or whenever there is a mild variation, or when they're newly diagnosed with COPD. So COPD has local as well as systemic effects. So the local effects are definitely in, or let's say measured or seen in the respiratory system. But the concern is in respect to the systemic effects. Systemic effects means the effect this disease has on other parts of the body, which can be measured. So systemic inflammation, because it is a chronic inflammatory disease, skeletal muscle dysfunction, secondary to the loss of muscle mass, abnormal structure of function, and limitation of exercise, or let's say disuse. Potential systemic side effects include effects on cardiovascular system or on osteoskeletal system with bone mass, as well as the skeletal muscle mass will be affected. So as dietitians will be more focused or more interested in nutritional abnormalities and weight loss that is seen. So now let's look at the nutrition of the diet component. How frequently do you or do any practicing dietitian assess a stable patient in the COPD? It's very rare. It's because if a COPD patient also has some other comorbidity, maybe an uncontrolled diabetes or uncontrolled hypertension, or let's say obesity, only then they are referred to. Whereas it is very, let's say, we get very less references, okay, only to manage a patient with nutrition problems in COPD. So malnutrition is a common problem seen in patients with COPD, but often underdiagnosed because it is a clinical blind spot where patients are not bothered to be assessed for changes in nutrition status until they end up in, let's say, a cachexia, state of cachexia, or severe loss of weight or muscle mass. So what does the literature tell? So weight loss is reported in 25 to 40% of patients overall. Low skeletal muscle mass will be seen usually increasing with the severity of disease. There are 4 stages of disease: mild, moderate, severe, and very severe. So 20% of patients in mild to moderate state may be having a low skeletal muscle mass, and up to 40% in case of COPD. Among inpatients, 30 to 60% of them can be malnourished, and among outpatients, 10 to 45% can be malnourished, which is again a huge number, at least 1 to 4 in every 10 patients seen. And cachexia, which is characterized by loss of both muscle mass and fat mass, is again a routine now finding when body composition data is available or when body composition measurements are done. And that ranges from 10 to 15% in moderate COPD, and in severe COPD, maybe up to 50%. So what is the reason? Why is it leading to such a change or such a decline in the nutrition status? And it's not like COPD will lead to only undernutrition, because we have all the spectrum. That is, even obese or overweight COPD patients are seen, and underweight patients are seen, and even normal weight patients are seen. So the concern here is it depends upon the phenotype of disease that is seen. So emphysema patients usually are more of cachectic, whereas the bronchitis patient usually are in the normal to overweight or obese body type. So here the increased respiratory muscle work, because there is a difficulty in the gas exchange or the breathing process itself. So there will be excess use of the respiratory muscles. And in this case, there is also decrease in the efficiency of functioning of these respiratory muscles with continuous demand, which finally leads to a mechanical insufficiency, and this cycle continues. And these patients are characterized by using their accessory muscles, that is the non-routine muscles, other than the chest muscles, for their breathing process, which adds on to the energy expenditure. In simple terms, extra muscle usage, or let's say the more muscles used for a particular kind of activity, the more expenditure and the more demand for nutrients and oxygen will be there. And what is the grade, or what is the severity of increase? So the resting energy expenditure may be usually increased by 15 to 20% above normal in normal weight patients, whereas in depleted patients, it can be as high as 70% than normal requirement. So other than that, along with the increase in energy expenditure or requirement, these patients also do report reduction in food and nutrient intake. Second, to the symptoms or the fear of getting exacerbation or worsening of the symptoms. So fatigue during eating, early satiety, loss of appetite, depression due to the disease itself and the limitations caused by the disease, the dyspnea, secretions, and inability to perform the routine physical activity. All these lead to serious reduction in food intake, Metabolically speaking, there prevails a state of negative nitrogen balance because again, energy intake is down. The muscles need to work more. So amino acid pools are used up quickly. The inflammation, ongoing inflammation also leads to activation of protein degradation pathways. Other than this, because of the use of corticosteroids, a medicine that is very frequent component in the total drug therapy of patients. So corticosteroid usage is also linked to negative nitrogen balance, depletion of calcium and vitamin D there. So the risk of osteoporosis increases in these patients. And since muscle function is higher compared to a normal patient with no respiratory disease such as COPD, the status of calcium, magnesium, or phosphorus that may lead required for normal muscle function also becomes important or depleted. So what are the outcomes of malnutrition in this case? What does it happen? How does it affect the prognosis? So reduce muscle strength, reduce respiratory muscle function. So the severity, or let's say the patient's condition itself worsens, and the demand for an advanced support or dependency on hospital, or let's say longer hospital stays, more frequent admissions, and more frequent expenditure in terms of healthcare costs to occur. So this also, that is a state of malnutrition in COPD, also leads to decreased exercise capacity. So it's not only exercise, because we can call it as physical activity, because the usual task which a person performs, which can be the daily, the work with that is an important part of source of income as well, even that will be affected if the person is carrying out a moderate to heavy physical activity nature of a job or something. So how do we treat it? Before that, how do we identify it? So as dietitians and the NCP, so we have to link that. So I'll speak in that ADIME format. So assessment is a crucial step. So we all know ABCD, right? Anthropometry, biochemical, clinical, dietary. It's the same thing, but here, just anthropometry with say height, weight, waist circumference, or hip circumference, and the usual BMI calculation or inferences may not help you. So here the history of weight loss is important, and changes in body composition is crucial, because body composition do vary a lot, and which may not be reflected in BMI alone. So serum protein state, yes, can be depleted, or let's say can be varied or reduced in severely malnourished patients, otherwise not much of variation. History is important, again, to know the disease years, to know the socioeconomic status, affordability to purchase of food, or there a lack of awareness in terms of avoiding certain food habits, or let's say in the smoking, that is a major cause here. And if there are any anxiety related to the disease, use of certain medications that may further enhance the nutrient needs, and the patient's physical ability. Is there someone whom he or she can depend on for obtaining food, or if he's the sole person, or let's say a single person who has to earn, who has to purchase, who has to cook and feed himself, then again, that might be a limitation. So all these factors need to be taken care of. So why does BMI reflect the true body mass or true changes? It's because there is a picture here, let's say in simple terms, a scan image of the body composition. So the yellow component indicates, so the part indicates fat mass, and the red one indicates fat-free mass. So on the outside, all the three patients do appear to have a similar body mass. But if you look at the red, or let's say the muscle mass, the patient C has the most muscle mass, whereas the patient A has the least muscle mass among the three. So this cannot be ascertained or measured with just BMI alone. So the measurement, or let's say separate measurement with a validated measure, such as measuring the body composition by bioelectrical impedance analysis, because we have a lot of portable machines available, they can be helpful in evaluating the changes, because here it's not a one-time identification. Since this is a chronic disease, changes keep on happening, and progressive depletion or progressive deterioration is what a dietitian has to catch, monitor, and then start intervening. So why is it so important? Again, what does the literature tell? 18 to 36% of COPD patients do present with muscle mass loss, and the major reason for weight loss is the muscle mass loss than depletion of fat mass. See, it is not a simple state of starvation where due to various reasons the energy intake comes down and there is initial weight loss or fat loss and the body gets adapted. No, there's no adaptation here, because the cachexia or the inflammatory profile of the disease is progressive in nature. So various tools are there, again, frequently discussed. So use of such tools definitely help in identifying that. So now I'll just give two examples of a PES statement, or in other terms, nutrition diagnosis that may be encountered. So the common problem or the nutrition problem seen is early satiety and COPD related involuntary weight loss. or let's say inadequate food intake, inadequate beverage intake, inadequate water intake, or inadequate protein intake. These are all the usual nutritional problems or diagnosis seen. So these are just two sample statements. So involuntary weight loss related to early satiety, problems with breathing and swallowing, and inadequate intake of calorie-dense foods, as evidenced by more than 10% weight loss and fatigue at mealtimes. This is one diagnosis, maybe of one patient, and the other diagnosis can be low protein intake. Reflecting that. So inadequate protein intake related to early satiety and food knowledge deficit, as evidenced by lab values of total protein measures of 5.8 gram per dl, albumin of 3.3, mid-arm circumference of 50% of standard, and the recall data giving you a value of less than 30 gram of protein intake per day. These are just illustrations that may be thought upon later, because we have very good materials that will help you in using the standard terminologies. So then what to do? What are the goals in nutrition care of these patients? If you have a patient who is losing weight or is at risk of getting undernourished, then repletion and maintenance will be important. And in case of obese or overweight patients with COPD, mild weight loss may be beneficial, or at least maintain the weight so that further weight gain may be avoided. So the major focus will be to provide balanced nutrition and not just focusing on the quality of protein or the total quantity of protein, but the concern is to spare the protein so that protein is used for muscle metabolism and not for energy synthesis, because amino acids are very important. This is a state of depletion. So energy requirements, yeah, there are many equations which have already been discussed. So there are various research articles where several equations have been evaluated for their accuracy or errors that may happen. So avoiding overfeeding a patient is very crucial here, because it is directly related to respiration, right? So what happens with increased, or let's say excess or extra provision of energy? It's simply the substrate use increases and there'll be more production of carbon dioxide. So depending upon the patient's respiratory symptoms, changes in the respiratory symptoms, nutrition impact symptoms such as satiety, at what quantity does the patient feel fullness, etc., you can gradually increase the provision of or increasing the extra calories that you need to give. So 1.2 to 1.3 to start with, and in depleted patients the target will be 1.5 times RE. And one study in moderate to severe COPD patient, they have again quoted that that's a better equation, even better than Harris Benedict, can be used. And protein 1.2 to 1.7 gram per kg is crucial, and at least 1.5 in patients who are having a progressive weight loss is necessary. Carbohydrate, yes, we do consume more of carbohydrates, but there are many literature, let's say reported literature quoting the benefits of a low carbohydrate, high fat diet, but that may be beneficial, let's say when the patient is in an exacerbated state or on enteral nutrition and on ventilator, then yes, that may be very obvious to use it. But again, in a daily basis on a stable patient who is in the community coming just for a follow-up and some changes, this may not be necessary. Around 20 to 30% of the total calories can be from fat, but again, increasing fat should not affect the satiety. That should be taken care of. Water, yes, 30 to 50 ml per kg body weight is more than sufficient. If you can meet the RDA of vitamins in stable patients, that is fine. Whereas in patients who are already depleted, admitted inside the ward for some exacerbation, then there may be extra requirement for calcium, phosphorus, vitamin D, because again, reduced physical activity, or they may not go outside to work at all, because even a small, let's say a 10-meter walk can start inducing dyspnea and worsen their symptoms. So take care of that. And increasing the nutrient provision excess than RD, or let's say more than RD, depends upon the individual situation. So functional foods and nutraceuticals, the overall literature provides a protective effect rather than a treating effect. But yes, when we are aiming at increasing the anti-inflammatory profile or antioxidant profile, then yes, we have many foods, convenient foods nowadays, such as green tea, which is so easily available, right? So there are many other combination of foods that can be easily consumed. So yes, they may be tried, but again, you can try these in a stable patient, but not in a patient admitted to the ward or the ICU. So nutrition counseling is the final step of intervention, where you also educate the patient, tell them not to overeat, avoid gas-forming foods, eat smaller bites, smaller meals, and eating in a slow, let's say in a slow manner, and not to gulp, because aerophagia, too much of a bolus of food can also lead to early dyspnea or early satiety. So resting before eating is very important because again, the calm environment is very crucial. Otherwise the patient starts, they'll usually have this anxiety associated with food. If you give a fried food to them, they'll be fearful. Or if you add just a teaspoon of ghee or oil above the chapati or the dosa to them, they'll be fearful. Their concern is whether this oil will cause exacerbation of symptoms. So be careful with that. And oral nutrition supplements are important because they are necessary. It is not a very simple state of disease where there is just inability to consume food, so I'll just add another meal. No, that doesn't happen. So if you have included some ONS or some other form of diet or dietary modification where the nutrient density increases and the quantity reduces, then that will be an ideal option rather than just repeating the same meal or splitting the same meal into two. So whole grain cereal products, because fiber is again crucial here. We don't want constipation to occur and further worsen the GI symptoms or the nutrition impact symptoms. Pulses, yes, take care of the bloating part and then decide. Vegetables and fruits combined up to 5 cups per day in divided doses are definitely required. Milk, the use of milk in combination with fish meat and poultry depends upon the diet pattern, whether the patient is a lacto-vegetarian or a non-vegetarian. If he is a total vegetarian or a vegan, then yes, you may also depend on some of the specific supplements. But yes, use of again oral nutrition supplements do help you in meeting your targets. So what do you want to monitor here? The end part here, it doesn't end, and the patient usually takes a lot of time to accept the dietary changes in terms of the meal size. It is not the composition. Let's say you may add a very a food that is usually favorite, or let's say a favorable for the patient in terms of likes and dislikes, but even then the associated changes in respiratory symptoms becomes important in their adherence to the diet. So it takes a lot of time, maybe 1 or 2 months to get used to that. Get used to the meal time, meal pattern, okay, and the consumption of liquids and all. Calculate the adequacy of nutrients met, because this is not a one-time follow-up. You may require at least 3 to 4 sessions monthly once in order to establish at least consistent intake of foods or nutrients as per your plan. So why is ONS mentioned everywhere in the last 3 or 4 slides? It's because as I told, the food size is more complication. I mean, that can lead to a complication here. So ONS indicates a simple oral nutrition supplement, okay, that can be easily reconstituted and easily consumed, easily carried anywhere. Now you may tell me there are many commercial ones only. What if the socioeconomic status is bad? Then we have options to develop some oral nutrition supplementations that can be consumed orally, but more importantly, prepared from the localized foods. So that was a major objective of my PhD topic as well, where we developed a food formulation based on the commonly used food ingredients, which was almost 30, let's say 70% less in terms of cost. But at the end of 3 months of intervention, in most of the patients, we could achieve most of the benefits that are mentioned here. So these benefits are from the literature. That is improved hand grip strength. We did observe that. Improved respiratory muscle strength, we could not measure that. Improved exercise performance, yes. The patients whom we supplemented were able to walk further, let's say extra distance of meters in terms of walking distance, and they also completed that within lesser time as compared to a pre-supplemented state. And there was improvement in patients' nutritional intake, because again, commonly consumed foods and my targets, or let's say the team's targets of deficit nutrient were met. Weight was improved, but yes, majority it was the fat intake, because we gave intervention for 3 months, but we also had improvements in muscle mass, especially the appendages, or let's say the legs and hands. If you look at the body composition wise, because we did a segmental body composition analysis during the intervention progress. Ultimately, the way these patients feel, that is more important. That is otherwise termed as quality of life. With proper nutrition plan, or let's say nutrition care plan, and with the use of ONS, there is a very strong research that tells you can improve the quality of life of patients, because they feel more confident that yes, they also can start some activity, they also can go out of the house. Otherwise, before the use of an ONS or a modified diet plan, they were not able to do, because they used to always complain that yes, after 10 meters, I know I'll be tired. Even if I'm not I don't have a strong respiratory symptom, I'm tired enough, making me restrict my activity. So ultimately, ONS will help in meeting many of the micronutrients, because majority of the commercial ones are fortified, and they help in increasing the energy and protein without affecting the dietary intake, especially in terms of meal size. What does the ESPEN recommendation tell? So even that recommends frequent
Sorry
small
to
amounts of
interrupt,
ONS.
Dr. Chandan, sorry to interrupt.
Yes, ma'am.
4 minutes like.
Yeah, just one more slide.
Thank you. Thank you.
So SPEN recommendation also supports the use of ONS. But again, we have to take care of the dyspnea, which is again labored breathing or difficulty in breathing, and the satiety, because we have many pulmo-specific products that may also contain more proportion of fat, maybe 25 to 30% in them. So the summary is nutrition screening, that is nutrition screening and assessment. Okay, because you screen all the patients with COPD whenever available and feasible. And when you find the patients at risk, then you go for a comprehensive assessment. So assessment with a body composition is any day or any time advised, because that helps you to, let's say, avoid weight loss or avoid the patients getting into a depleted state. So optimal nutrition strategies should focus on not just energy or not just protein, but overall macro and micronutrient profile. And the use of ONS is an easy step to complete or meet your target as well as the patient's target. Thank you.